Preparedness and Strategic Response to Monkeypox in Nigeria. You're welcome, DG.
Well, thank you very much for this very rather generous introduction, and I'm grateful to the audience, the organizers of this meeting for inviting me to speak among you at this event, along with your other illustrious speakers. I'm just going to try to share my screen now. I'm not sure if I've got permission to do that. Okay, let's just do that now. Do I have permission to share my screen?
Yes, you do. As a panelist, all panelists have permission to share screen.
Okay. Just do that.
Ife, can you look into that, please?
Okay, yes. I think we've got it now. All right, so thank you very much. I hope everybody can see this.
Yes, we can see your screen.
All right, great. Okay, so I'm sure that a lot has been said about the history of monkeypox. So I summarized this rather busy slide by sort of saying that the first human case of monkeypox in Nigeria was reported in 1971. We had occasional few cases between 1971 and 1978. And then for 40 years, there was, or thereabouts, there's a complete gap, only for us to sort of record reemergence of monkeypox in 2017. And since 2017, we have had sporadic cases every year, including this year. We have at the NCDC been managing and reporting monkeypox since 2017 with detailed situation reports on our website, which of course means that as a consequence, in the West African region, at least Nigeria has had the most experience of reporting monkeypox cases. And while this is a measure of success, it also means that it's meant that unfortunately we are almost always in the conversation about monkeypox because we've done the most reporting in the sub-region. And I think it's important to remind the audience that zero reporting is not equal to zero cases. And as we are finding out, there are actually quite a number of countries in the West African sub-region and beyond that do not actually have diagnostic capacity for monkeypox. So there's really no way they would have been able to diagnose or report any monkeypox cases occurring within their boundaries. So I'm sure you've gone through the current global epidemiology. The countries in Africa have dealt and continue to deal with monkeypox for a long time. The renewed attention given to monkeypox as a result of this outbreak in non-endemic countries, of course, now makes it suggest, along with the narrative, as if this is something new, or now there's a crisis or an emergency everybody needs to be scrambling to respond to or resolve. But monkeypox has been in existence in West Africa, in Central Africa, and countries have continued to deal with them. And if you look here, you can see that in this year alone, this is the record, this table 2 shows the record of confirmed cases versus suspected cases and deaths from monkeypox this year. In West Africa, yes, Nigeria and Ghana, distant second, has done most of the reporting, but I think it's important that we also keep an eye on what's happening in the Democratic Republic of Congo, where they have been quite a large number of suspected cases, and we know that that's a very challenging setting, but with a lot more deaths from what is a different clade of the monkeypox virus. So in terms of Nigeria specifically, we've had 141 cases reported, suspected cases reported from January 1st to 2 days ago. Out of the 141 cases, suspected cases, we have confirmed 36 and we've recorded 1 death. So since the emergence of monkeypox in 2017 to date, we have seen a total of 262 confirmed deaths and sadly recorded 9 deaths as shown in the table. Just to give a sense of what has happened over the years since monkeypox re-emerged, this is a table showing the suspected versus confirmed case and the test positivity rate. Now, this is the picture. If you take the cases by the time periods in which they were identified, this is what we are seeing. Yes, we now have what looks like an uptick in the number of suspected and confirmed cases starting from about the end of May. And this is due to, again, the news and the increased reporting associated with monkeypox means there are a lot more people reporting suspected cases, and we expect that this number will continue to go up given all that is happening in the news. We have seen a predominance of males versus compared to females, both when you look at cumulative number of cases or even when you look at the number of cases that have been recorded in just this year alone. So if we just, again, look at the distribution of cases across the country from 2017, when monkeypox re-emerged to date, what you see is a lot more states, a lot more cases coming up. And we had previously sort of, especially in 2017, seen more cases in the South. And it was assumed that for some reason, the South is the area of predilection for monkeypox. Of course, it's where most of the forests are, where it's where we've got monkeys that were thought to that are thought to be the main reserve, one of the animal reservoirs, and other animals are present. And of course, we know that in this part of the country, we also like our bushmeat and you know, the other animals that are considered a delicacy. But as you can see, we now have monkeypox in Abuja. We've seen monkeypox in Kano. We've seen monkeypox in Adamawa. Actually, we know that there's monkeypox even in Plateau, although it was, I think one of them was an imported case. But the point is, with increasing our awareness, increasing reporting, it is likely that we have monkeypox across the country, and we just need to continue the work in the area of risk communication and community engagement, and of course, work on increasing the awareness of frontline healthcare workers to reporting cases, even the more conventional or familiar chickenpox, to authorities to allow samples to be taken for diagnosis. So if we look cumulatively, when we put all those maps together from 2017 to date, what we have is 23 states have reported cases of monkeypox. This is the trend. Comparing all the years together, we can see what happened in 2017 and the peak that was reached. We are watching this trajectory for 2022, which seems to have picked up now. But again, it's like when you rustle bushes. If you rustle bushes, the animals will come out. If you don't, you might think there are no animals there because everything is quiet. So the more we look, the more monkeypox makes the news, the more engagement we have with communities. And so the more likely we are to find cases which will contribute to a sharp increase before we then achieve what would be considered the appropriate stable level. So when we look at all the cases that we have seen so far this year and in the past years, and compare some of these to some of the reports from elsewhere, we haven't, in our case, seen any changes in the what may be considered changes in disease transmissibility. We have documented transmission or we think there is transmission by close contact during sex, but we haven't been able to confirm yet that we have monkeypox in the conventional sense of a sexually transmitted disease or infection is happening here, and we are going to work on collecting samples, relevant samples to test, to be able to provide some context-specific answer to that question. We are sequencing all samples, and we know to date that all of the positive cases we have are still caused by the West African clade. I hope that name gets changed soon. But we are working on a deeper dive into the genetic or genomics analysis to see if there have been any changes specifically in the virus that may contribute or may explain whether it's better adapted to humans, or as a result of that adaptation, maybe it's become more efficient at human-to-human transmission. But that is still work in progress. And the clinical manifestations have stayed the same. We have not, for example, if you compare to the reports that are coming from elsewhere, we haven't seen more genital or anogenital lesions, which might, again, maybe suggest that we are seeing a situation similar in terms of transmission to what is being reported elsewhere. And we do need to be careful not to bring up any especially when unproven, any thing that may lead to stigmatizing of monkeypox and then affect reporting and surveillance. Sadly, as some people may know, the NCDC has published work that reported, unfortunately, the death by suicide of a monkeypox case who sort of became really depressed and worried about the stigma that they experienced, not this year, previously, when they came down with monkeypox, which was considered an unknown and strange condition. So we really have to be careful about the narrative and not necessarily copy and paste narratives from elsewhere that may affect the way we surveil, detect, and manage monkeypox in our own part of the world. In terms of our response activities, we've got monkeypox specific guidelines. We've got real-time reporting with our electronic surveillance system. We continue to provide technical support to high body states through sample management and surveillance strengthening. And we are trying to expand capacity at the National Reference Lab for monkeypox diagnosis. We've previously had one source of monkeypox laboratory reagents, but we are looking to validate test kits, test options from other sources in the bid to make sure that should there be a need, a real demand for such testing, that we can actually do that. This is a summary of what the case-based surveillance for monkeypox is in Nigeria. We need to have suspected cases reported. That's people who meet the case definition. So please, if you're in doubt, if you see any case that looks like monkeypox or even looks like chickenpox, and you're in doubt, please report to the relevant authorities in your state. So the disease surveillance and notification officers, your state epidemiologist, or your people in the Division of Public Health in your state ministries of health, because it's when that reporting occurs that appropriate sample collection will be done. And we have mechanisms in place to have those samples picked up and brought to Abuja to be tested. And our aim is to have a 24-hour turnaround testing and release of results to colleagues who collect these samples, so that they can conduct contact tracing, make their line lists, and all of the other associated activities for response. So this is the case definition. If you have anybody with who is acutely ill, has a fever, headache, lymph node swellings, back pain, muscle pains, and develops a rash, typically, then that's a suspected case of monkeypox, especially if you've got a rash that includes the soles of the feet and the palms of your hands. Probable case meets this definition. It's not laboratory confirmed, but we can show that they've been exposed to a previously confirmed case. And of course, confirmed case means they've got all the clinical symptoms and they have a laboratory test that confirms the presence of monkeypox. So there's a lot in the news about monkeypox, which suggests or has been interpreted in some settings as if countries in West Africa, Central Africa that have been looking after this condition for years have not been doing anything. So I think it's important, despite recognizing challenges that we have, to talk about some of the things that we have done okay in the country that has led to us, of course, reporting consistently more monkeypox cases than in other places. So we take a One Health approach to our response. And One Health means you're looking at a disease, not only from the human health perspective, but also taking into account the animal health perspective. And I don't know if it's been mentioned before, monkeypox is a zoonotic illness. So it's caused by a pathogen, the monkeypox virus, that affects both humans and animals, or affects animals and spill over to humans. And zoonotics are important because it is, of course, SARS-CoV-2, cause of COVID, is a zoonotic pathogen. So is Lassa fever, so is Ebola, and all of a range of Middle East respiratory virus, a host of other pathogens. And we know that with sort of increasing urbanization, population growth, globalization, and all of the narrowing of the interface between human and animals, we expect that next pandemics or major outbreaks will be caused by pathogens that are zoonotics. So it's important that we take a One Health approach to preparedness and response. And I'm sure you've caught up with the rest of the bullet points here. So we've got, of course, human capacity development for case detection. We were able to in a timely and effective manner contain the 2017 outbreak. And even before the drive came from externally, we had integrated monkeypox into our list of integrated disease surveillance reporting of notifiable diseases, and of course constituted a monkeypox technical working group, which is always active in the background to coordinate activities related to monkeypox surveillance and response. Our research priorities at the moment is to confirm the animal reservoir for monkeypox in the country, because previous efforts, while they've identified orthopox viruses, that is the larger family that this virus belongs to, members of that family have been found in a range of animals, rodents, and the like in the country, but none of those studies have actually identified monkeypox itself. So as far as planning interventions, from the animal side of things, that so far cannot be targeted because we do not know which animal in particular. And we are doing some additional work in that space. And we know that these colleagues elsewhere are also doing some animal work of course, all in conjunction with the Federal Ministry of Agriculture and Rural Development, to try and see if we can confirm the range of animals that might be reservoirs so that we can plan interventions appropriately. We are quite keen to determine what is cumulative exposure. That's what's the population level exposure of to this virus by looking at representative blood samples and testing for antibodies to monkeypox, which will be a sign that anybody who's got antibodies to monkeypox virus have previously encountered the virus. We continue with our genomics work. We are interested in properly characterizing the entire range of transmission, including sexual, and if there's sexual transmission, how long, for example, would monkeypox virus live in the testicles or in seminal fluid, etc., etc. Of course, a lot has been said about vaccines and therapeutics, which we currently do not have any access to. We are, of course, exploring through partners, gaining access to some supply of vaccines and therapeutic agents, with a view of having those in place so that we can have options for those who are at high risk of developing severe disease or even adverse outcomes. These are some of the challenges at the moment. Obviously, there's a very low risk perception regarding monkeypox in the population, especially since it's thought to be associated with low fatality. We need to increase our awareness among our frontline healthcare workers. We need to diversify or expand the options for supply of monkeypox laboratory consumables for diagnosis. Of course, we need to leverage and find more resources to devote to monkeypox surveillance, not just monkeypox surveillance, to surveillance of sort of all relevant emerging and re-emerging pathogens and those that have of epidemic potential or epidemic prone, and to, of course, fill our gaps in knowledge regarding monkeypox. So we areas of improvement, of course, we need, which is why I like to commend the organizers of this meeting. This provides a means of not just sharing information, but also providing evidence or ammunition for advocacy. We need sustained and intensified risk communication. We need to find, of course, the public health workforce is a very small one, so we need more people. We need to strengthen surveillance, healthcare financing, so that if people have universal access to healthcare, then there will be no reservation about going to hospitals. And then it means that conditions that are important that should be notified will be picked up increasingly. We would look into expanding capacity for testing, should there be a greater demand for testing, and to leverage funding for research. So to conclude, monkeypox is endemic in some parts of the country. The epidemiology appears to be mostly stable over the last 5 years since it re-emerged in 2017. We've made some progress in detection and response, but there is need for sustained preparedness and response efforts for monkeypox, and indeed all other relevant epidemic-prone or epidemic or emerging and re-emerging pathogens. And this is not just the federal government's responsibility, it's not just the NCDC's responsibility, it is all of our responsibilities across states, local governments, health facilities, policymakers, advocacy groups, civil society organizations, professional groups, and the like. We all need to work together to assure our health security, and to remember that there are 36 states and 1 federal capital, 774 local governments, and we will only be as strong as our weakest link. Thank you very much.
Thank you very much for that.